Can hear me okay, and thank you for joining us tonight. I'm Dr. Holt, one of our hand and upper extremity surgeons, and we'll talk about carpal tunnel syndrome, try to give you a big overview of risk factors, causes, treatment options, and all that, and certainly be happy to answer any questions that I can afterwards. So I'm a board certified surgeon here. I do primarily hand and upper extremity, kind of hand, wrist, elbow, and a little bit more surgery. Initially started practice after fellowship in Knoxville, Tennessee. Worked there for a couple of years, and then came here to Central Oregon and been in 2018. Been here since and really enjoy being here and happy to take care of our community. So carpal tunnel syndrome, as I said, we'll go through the diagnosis, risk factors, treatment, surgical options, surgical treatment, and kind of expectations after surgery. So what is carpal tunnel syndrome? Our term is a compressive neuropathy at the wrist. What does that mean? Compressive is just pressure, and neuropathy is relative to a nerve. So essentially there is too much pressure on a nerve, what we call the median nerve, as it passes through your wrist into your palm. And so here's a good diagram. This yellow is the median nerve. That nerve starts all the way in the cervical spine, passes in front of the shoulder, down through the arm, the elbow, forearm. And then as it passes through the wrist, it runs through a tunnel comprised of some of the small wrist bones, ligamentous structures, also the tendons to the fingers run through that tunnel, and that is the carpal tunnel. And carpal tunnel syndrome, therefore, is when that nerve has too much pressure on it as it passes through this tunnel. Symptoms probably most common is numbness and tingling. Classic is basically the thumb, index, middle finger, and generally half of the ring finger. There can be some overlap with some of the other nerves, but that's the kind of classic pattern of numbness and tingling. People often get burning pain, classically in that same distribution, although it can spread throughout the hand or in different areas. A lot of people will describe these shock-like symptoms, electricity type feeling in the palm and in their fingers. As it progresses, or people that have had it for a long time will develop some weakness. This nerve does primarily sensation once it gets to the palm, the median nerve, but it also innervates some of the small muscles, especially in our thumb. And so people can start to develop some weakness with kind of severe or chronic carpal tunnel syndrome. Similar to that, start to get difficulty with fine motor skills. Some of that can be the numbness, the sensation. Some of that can be the muscles if they're not being not as active as normal. A lot of people also get some swelling and stiffness, especially at night and in the morning. So how do we diagnose it? Oftentimes just on history. Many patients come in with a very clear classic description. You know, they have numbness and tingling in this description, thumb, index, middle finger, sometimes in the ring finger. Symptoms are very common at night and is often what will bring patients into our clinic. They can't sleep through the night. They wake up, your hand is burning, it's tingling. You have to stretch it out. You have to shake it out. And when you can't sleep, it becomes a big problem. And that's often what drives patients into our clinics for us to evaluate. Often can get aggravated with really any sort of repetitive activity. A lot of people complain of worse with driving, using electronics, sometimes work duties, and other activities. Physical exam, most of our tests are based on kind of recreating that compression on the nerve. There's a lot that have been described, but essentially most of them are going to involve us either tapping directly on your nerve or putting some pressure on your nerve to recreate those symptoms. We will at times get what's called a nerve conduction study or an EMG. I'll go through that in a minute. Also on kind of history and examination, this is a kind of a case of severe carpal tunnel syndrome when people have had it for years. That nerve has really had some chronic severe compression. What will often happen is there'll be some wasting of the muscles kind of down around the base of the thumb. And when we see that, that's pretty classic for like a very severe long-term carpal tunnel syndrome. A nerve conduction test or EMG, they're related but different, is basically a way to test your nerves. Nerves pass electrical activity to lead to their actions, such as sensation or motor function. And so these tests can evaluate that electrical activity and determine where your nerve is compressed, how bad it's compressed, to determine for any sort of nerve damage or potentially any other additional diagnoses or alternative diagnoses that may be causing some of the symptoms in your hand. So risk factors, there's a lot that have been described. Diabetes, hypothyroidism, inflammatory arthropathies such as lupus, psoriatic arthritis, rheumatoid arthritis, A lot of these are things that increase inflammation in the body. We know that increased inflammation or swelling in the wrist or hand can lead to increased risk of carpal tunnel. It's more frequent in females compared to males. Certainly the incidence increases as we age, more common in obesity, tobacco, alcohol use. There's been a lot of studies that have shown occupations that have a high hand-wrist repetition rate lead to a higher risk of carpal tunnel. We see it not uncommonly in pregnancy, in which case it will often resolve after delivery, can also be caused by prior injury or development of arthritis in the wrist and surrounding areas. So as I was kind of alluding to before, I think, for most people, the easiest way to think about it is the end result is inflammation around the nerve, often in the soft tissues that are surrounding the nerve. That leads to swelling. And as the nerve and the tendons pass through this tight tunnel, there's only so much room. And so as that swelling increases, it causes direct compression on the nerve itself. So non-surgical treatment, really the number one treatment is a wrist splint. Here's a classic kind of over-the-counter wrist splint. The idea is to place the wrist in a neutral position. So it's not extended backwards too far. It's not flexed forward too far. By holding that wrist in a neutral position, many people can obtain excellent symptom relief, especially nighttime. That's kind of the first thing to start with. If you've got nighttime numbness and tingling, get a wrist splint or brace, wear it at night. And for many people, that's a big improvement in symptoms and can really manage symptoms. We will often do steroid injections. I tell patients that I think for most people, they're effective, especially for the pain. Sometimes they don't work as well for the numbness or in more chronic and severe instances, but oftentimes can help with the pain. The reason why the steroids work is they're a local anti-inflammatory that we inject not into the nerve, but in the area around the nerve to decrease that inflammation, decrease that swelling, and hopefully alleviate some of the pressure around the nerve. We do know based on experience and studies, I think for most people, not always, but for most people, they're probably temporary. They provide relief, but ultimately wear off and the symptoms recur. Oral steroids, somewhat similar, a strong anti-inflammatory, but taken orally as opposed to injection, tend to give a lot of relief. Also, in many cases, likely temporary, but often can give very quick and good short-term relief. I mentioned on here ergonomic changes. There's been quality studies that show ergonomic changes likely don't change or affect carpal tunnel long-term. But that being said, I think many people can make some ergonomic changes that really can at least limit their symptoms temporarily, make them more functional at work, and we'll go through some of those examples. So steroid injection we talked about. This is how we do it here in clinic. Basically place a needle into the carpal tunnel, not into the median nerve itself, of course, but around the nerve, inject a steroid to give a good anti-inflammatory and hopefully decrease some of that swelling and inflammation right around the nerve. Oral steroids, prednisone is a very classic or common oral steroid. There's some others that we can use as well. And then ergonomic changes, just feedback from patients and recommendations for some people. Things as simple as using a stand-up desk where you can get your wrist in a little bit more of a neutral position can help. There's ergonomic keyboards that can help. This is a vertical mouse here in the picture in the middle, which I've not used personally, but feedback from some patients can really help just by shifting the position of your hand and wrist and getting it in a little bit more neutral position rather than that kind of constant wrist bent position that we often use with a regular mouse or a keyboard. There have been lots of other things that have been tried. All these that I've listed here: acupuncture, laser therapy, magnet therapy, visiting a chiropractor, even standard anti-inflammatories, and many other treatments. These have all been tested and unfortunately haven't really shown any significant results for large groups of people. I tell patients that when we do studies, our goal is to find what's the best treatment for the average person. It doesn't mean that some of these things may not provide benefit, or especially short-term benefit for certain patients. But when we look at them, on a large scale, multiple studies, lots of patients, they don't show any long-lasting or significant benefit. I'll often recommend NSAIDs for short-term, and I do think that taking anti-inflammatories, NSAIDs such as ibuprofen, can give some short-term relief. But somewhat surprisingly, most of our studies suggest they likely don't change the course long-term, but certainly can provide some short-term benefit. So that kind of gets to surgical treatment. We've got pretty good evidence. This is a statement from the AAOS, which is our American Academy of Orthopedic Surgeons. They've put out these clinical practice guidelines that basically look at all of the evidence available, try to, analyze that evidence, put it together the best we can to come up with recommendations. And so one of their recommendations, a very strong recommendation, is that strong evidence supports surgical treatment of carpal tunnel syndrome should have a greater treatment benefit at 6 months and 12 months compared to basically the other non-surgical treatments, splinting, anti-inflammatories, therapy, and a single steroid injection. So again, when we look at large studies, lots of patients taken out 6 to 12 months from initiation of carpal tunnel symptoms or when a patient presents to a hand surgeon, on average, patients will likely be better off at 6 months and a year proceeding with surgery than some of the other conservative treatments. That being said, I always think it's so very patient specific. Some patients' symptoms are very short term, they're very manageable. We can get them under control with non-surgical treatment, even if perhaps they're going to recur down the road. Usually starting with non-surgical treatment is very reasonable, and many patients respond to that and can have their symptoms under control. And I'll often see patients with carpal tunnel that will tell me, a doctor told them they had carpal tunnel 10 years ago or 15 years ago, and they've treated it conservatively for that long. And maybe they ultimately got to surgical treatment, but were able to really manage their symptoms for a prolonged period of time. So I think the most important thing is just having a discussion with your surgeon, your doctor, and finding out how long your symptoms are, how significant that are, what non-surgical treatments you have tried. And then many times attempting some non-surgical treatment makes most sense. Kind of getting back to this previous picture, some of it comes in with this kind of wasting of the muscles, severe symptoms. I'm going to tell that patient, hey, we can try some non-surgical options that may help with your pain, but we're not going to stop your carpal tunnel. At this point, it's very severe, and really the only option for a long-term solution or preventing additional damage would be surgery. Or someone that's already attempting a brace, kind of attempted a lot of the non-surgical treatments, then oftentimes surgery is the next step and a good next step. So when we're talking surgery for carpal tunnel, there's really two options. There's an open carpal tunnel release and an endoscopic carpal tunnel release. This is a little bit oversimplified, and I'll go through some of the details, but I tell people, think of an open carpal tunnel release as kind of an outside-in release, and an endoscopic means camera-assisted, as an inside-out release. So getting back to our anatomy, kind of one of those initial pictures, we've got some of the small wrist bones on each side of the palm. The median nerve, which is the nerve that's being affected, runs through this tunnel of bones, and over the top is what we call the transverse carpal ligament. That's this white band that's the roof, or kind of the top of the carpal tunnel. And here's a cross section up above, where at the bottom is the palm side, at the top is the back of the hand, and same thing, this nerve is running through this tunnel of small wrist bones with the ligament as kind of the roof, or keeping the tunnel tight, next to all the flexor tendons that go to your finger and palm. And so surgery for carpal tunnel involves releasing this ligament. I tell people, think of it as a tight rubber band. If we cut a rubber band in half that's under tension, it's going to spring open and that tension is going to go away. And so whether it's a open carpal tunnel release, an endoscopic carpal tunnel release, the ultimate goal of carpal tunnel surgery is to release this ligament, protect the nerve, but release the ligament and take pressure off the nerve to get symptom improvement. So for an open carpal tunnel release, many different incisions. In general, it's going to be kind of like a longitudinal incision in the mid palm. Some people will do a smaller incision, sometimes a larger incision, but this outside in, essentially start from the outside, make an incision in the palm, cut down and release through some thin tissue, what we call fascia in the palm. And then deep to that is that transverse carpal ligament, that thick band of tissue running across the palm to release, to take pressure off the nerve. For an endoscopic, instead of having the incision here in the palm, it's a small, usually crosswise or transverse incision, just above the wrist. Make a little small incision, and then over in this picture on the right, a camera goes inside the palm, deep to that ligament. And so this is more or less our view. We look inside the camera and we see the ligament above, or kind of at the roof, and then a little small knife pops up to release that ligament. And that's why you can think of it as an inside out. Make a small incision away from the ligament. I put a camera inside to the palm, see your ligament from the inside, and basically release it from the inside. But the ultimate goal is the same, whether it's the open carpal tunnel release, endoscopic carpal tunnel release. to visualize this ligament, to see it safely, to protect your nerve, and then to release that ligament to open up the space and take pressure off the nerve. And here's a couple various incisions that have been described. For me, and I'll talk about this a little more, I primarily do an endoscopic. I've also done open, and often we'll do that in potentially a revision case or a more complicated case. But my general preference for a first time kind of index primary carpal tunnel release is to do an endoscopic. And this is very similar to the incision I use, which is transverse and usually about a 1/2 inch just above the wrist. But some people will do a small open, what's called a mini open, a larger incision. Some of the endoscopic carpal tunnel release procedures or surgeons will use 2 incisions. For me, it's this one small incision right here, just above the wrist. And as I mentioned before, the goal, regardless of the incision, protect the nerve, cut this ligament to take off pressure, take the pressure off the nerve. So patients will ask, and we've done, or hand surgeons have done a lot of research on the differences between an open carpal tunnel release and endoscopic carpal tunnel release, which one is better. I think the number one thing is up here at the top. For symptom relief, are your symptoms going to get better or go away? The numbness and tingling, the pain. At 3 months, studies have shown there's no difference between the two. And likely by 6 months, if not earlier, you couldn't tell which surgery you'd had. If you'd had one on each hand, your symptoms on average would be very similar and your recovery would be very similar. There have been some studies that show with endoscopic, ECTR, endoscopic carpal tunnel release, in the early period, at 6 weeks, 3 months, people have a little bit better strength, a little better grip strength, pinch strength, a little better use of their hand at 3 months. Kind of like the symptom relief, likely by 6 months, there's little to no difference, and you couldn't tell one side from the other. Related to that strength, with endoscopic carpal tunnel release, studies have shown on average a quicker return to work of about 9 days, which can be significant for many patients. Complication-wise, most of our studies show major complications, no significant difference, very low rate overall of major complications. Very minor complications, which would be like temporarily increased pain, things like that. Endoscopic carpal tunnel release tends to show about a 50% less complication rate, but overall both show a very low complication rate, and both are very effective and I think long-term similar. As I mentioned, for me, I do prefer the endoscopic. I think for those reasons, I believe the studies, both with my patients, reading the studies and anecdotally, while I think long-term there's little to no difference. I think early on patients with the endoscopic have a little bit less pain, a little more function, can get back to use and potentially work a little bit quicker. And I think the main difference is probably just the location of the incision. When I put an incision here just above the wrist, it's a smaller incision, whereas the open procedure is not a big incision, but it's right in the palm. And so every time you kind of put, a patient puts pressure on the palm, rest that hand down, I think this can be a little more sensitive, a little more painful in the early period. Long-term, no difference, but probably a little bit more sensitive and painful just from the dissection and the location of the incision compared to the endoscopic, which is right here above the wrist. So complications of surgical treatment, I always tell people any surgery can cause complications. A major complication like an infection that needs treatment, a long-term nerve injury, or based on studies, significant pain beyond a year, again, with both very low rates of serious complications at about 1%. Minor complications are not uncommon. Temporary nerve irritation, occasionally the nerve that's released or some of the branches of that nerve will get irritated and even be a little more tingly after surgery, not common, but can have some temporary irritation. Regardless of the incision, the scar is going to hurt for a period of time. And then pillar pain, which I think I have a good picture of here. I think this is incredibly common and probably every patient gets some degree of this pain. And so back to our original picture, carpal tunnel, median nerve running through the carpal tunnel. This ligament's what's released. This picture kind of shows you more or less the ligament runs from these red dots to these red dots, so kind of across like a band. It is very common to get this pain down at the base of the thumb and the muscles, down at the base of the small finger or this side of hand in the muscles. And I would say, again, most patients have some element of that. Vast majority of the time that improves, and most of the time even goes away. And based on our studies, minor pain may persist, but any severe or significant pain, which is graded as basically moderate or severe pain beyond a year, is incredibly uncommon. But some pain is very common, and even some long-lasting low-grade pain can happen. So what to expect? I think most people, their questions are, hey, what can I expect out of this? And I always try to give patients very reasonable expectations. Almost without fail, if you have nighttime symptoms that are waking you up from sleep, that usually resolves immediately. Many patients will come back and say, hey, I could sleep through the night the first night after surgery. Patients, if you have had constant numbness, numbness that persists, that doesn't go away, doesn't just come at night or with activity, but is persistent numbness that you've had for months or years, you've developed weakness, you have that atrophy, that wasting of the muscles, a lot of that stuff will be very slow to recover and at times does not recover completely. That's what our nerve test can help to determine. Some patients, if this has been long enough, it's severe enough or chronic enough, will actually develop nerve damage. And the main goal of surgery is to prevent that damage from getting worse, hopefully obtain some symptom relief. But there is a small subset of patients that obtain little to no actual subjective improvement, but our goal is to keep things from getting worse, but the nerve has been damaged, compressed for so long, so severely that the nerve doesn't recover. So I think another big thing for patients is, hey, what can I do afterwards? How can I use my hands? So for me personally, I put you in a soft dressing. So it's a soft bandage, ACE wrap. I like patients to wear that for about 5 days, just to let the wound seal up, keep it clean and dry for 5 days, which is probably the biggest hassle with hygiene. After 5 days, you can wash your hands, take a shower, and get it wet. I tell people, go home and use your hand immediately. It's good. We want to avoid stiffness. Things will be sore, but it is safe and good to use your hand for what we call these light activities of daily living. You can feed yourself, put your clothes on, use your phone, use your computer, basically anything up to just 2 or 3 pounds. Again, some of those activities will be sore, some of them will be challenging, but they're safe and they're good. I always tell patients to limit repetitive activities. Also, vibrational activities or power tools can really set it off in the early periods. So for some people, that's motorcycles. Sometimes it's power tools, drills, lawnmowers, leaf blowers, things like that. But you definitely want to avoid that in the early period, or that can, I think, increase your symptoms and slow your recovery. As far as pain afterwards, for most people, it's very manageable. I would say a majority of my patients take little to no narcotic medication. Tell patients it feels like a deep cut. It's going to hurt, but it should be manageable. Most patients can manage that with ice, with elevation, over-the-counter medications such as Tylenol and ibuprofen. Expect some pain and weakness, likely for 3 to 6 months. For most patients, that's very minimal and manageable, but some symptoms can persist for 6 months or occasionally longer. And we have good studies that show it often takes about 6 months for the grip strength to return to your hands. Early on, I tell people elevate, keep your fingers moving. For me, the most important thing in that first couple of days is to avoid too much swelling or too much stiffness. If you have a few patients that kind of really struggle is if you just get a whole lot of swelling, whole lot of stiffness in the fingers early on, it can be hard to get past that. So big questions. When can I take care of myself? After surgery, immediately, but it might hurt. So getting back to my recommendations, use your hands, light activities of daily living, put your clothes on, feed yourself, self-care. Those things can be done and be done safely, but will likely be sore and painful. When can I go back to work? Completely dependent. I have patients that will go back to desk jobs, light work within 2 to 3 days after surgery. Again, it's probably going to hurt. You're probably going to be slow typing. It's probably going to be tough to type for 8 hours all day long, but I do have patients that will sometimes have a surgery Friday and go back to work on Monday. Up to 3 months. We've got good studies that most people should be able to return to work full duty by 3 months, regardless of occupation. Obviously, so much of this is patient dependent, your job, your demands, how heavy your work is. But in general, we've got good studies that patients should be able to return to work by 3 months. Getting back to the previous slide, though, quite possible, and I'll warn patients this, if you're doing heavy work, even at 3 months, you're likely still going to be sore from time to time. You'll likely still be weak, potentially be weak in your hand, but it should be safe and you should not damage it by 3 months. And I generally tell patients, I think for most jobs, with rare exceptions, it's safe to go back to work at 6 to 8 weeks, but expect some pain and weakness. When can I expect all the pain to go away? Well, based on those previous studies, I think for many people, it's 3 months to 12 months. With rare exceptions, there's minimal, maybe some mild residual pain, but very minimal pain beyond a year. Back to our complication rate, probably less than 1% of people have significant pain, kind of moderate or severe pain beyond a year. So for me, this is a surgery that is generally very successful, generally very low risk. Most people do very well. I tell patients no surgery is perfect every time for every patient. And any surgery we do, even a surgery done perfectly well, can cause complications or some persistent pain. But I think for most people, especially if you have those significant nighttime symptoms, this is a surgery that for the vast majority of the people gives significant relief with overall low complication rates and acceptable post-operative recovery. Okay, I think that's all I have for my slides. Let me get here to the questions and be happy to answer anything that I can. Okay, question about physical therapy, occupational therapy as conservative treatment. I think I maybe had one slight mention on a slide from the AAOS recommendations. It's a little bit back and forth. There's been some studies that show, in general, exercise is beneficial. I am not aware of big, I guess, review studies or what we call meta-analyses that show physical therapy or occupational therapy provides a significant long-term benefit. But going back to a lot of those non-surgical treatment options, things like acupuncture, laser therapy, NSAIDs, I think it can be very beneficial for the individual patient, certainly provide some functional improvement, maybe strength, maybe pain relief. When we study it on a big, broad basis, does it provide long-term relief? It seems like it doesn't, but everything is patient-specific. So it could absolutely, I think it can be beneficial. I'll often talk to patients about that and occasionally refer patients to therapy. So next question, dietary supplements recommended to reduce inflammation. Absolutely, we've got good evidence that I'd say the big three are turmeric, ginger, and fish oil have been proven to be in general anti-inflammatory. I'm not even aware of any studies specifically with those and carpal tunnel, but those have been shown in big studies, good studies, to be anti-inflammatory. I talked about that. I did a non-surgical treatment arthritis webinar, which several months ago, and really mentioned that. I think those can be very beneficial, usually don't have the same side effects as oral NSAIDs. Most people don't get any stomach upset. They can potentially interact if you're on a blood thinner. So if you have any significant medical issues, other medications, maybe check with your primary care doc. But absolutely, I think turmeric, ginger, fish oil, evidence-based, proven to decrease inflammation, and some patients respond to them very well for various issues. So a question about wrist braces over the counter. I think in general, yes, we have wrist braces here that we fit for patients. But I tell people all the time, if they want to purchase one over the counter, most of them will say a carpal tunnel brace. To have an effective brace, it needs to be comfortable, something that you're going to wear. So you want to have it, decent fit and decent comfort. And then for carpal tunnel, it needs to have some sort of metal or plastic bar or stay to keep your wrist in a neutral position. I do not believe a soft wrist, like a wrap, a neoprene wrap, a gel wrap, is as effective. But if you get a brace, it fits, it's comfortable, you're going to wear it, and it has a hard stay to keep your wrist in a neutral position and not allow your wrist to move, then absolutely an over-the-counter brace should be effective. Question about dosage for supplements. I apologize, I will have to look that up. I believe turmeric's 500 milligrams daily. I don't have offhand the dose for ginger, so I apologize. We can maybe try to, if we have some notes or something, or link that afterwards after the study. I think in general, if you go to a drugstore or grocery store and you find the supplement section, likely that's kind of a reasonable or appropriate dose, but I don't remember the exact doses offhand. So specific activities that should not be done after surgery. I think in the early period, it's limiting the weight, nothing more than 2 to 3 pounds. Definitely stay away from vibrational activities. So try to stay away from the vacuum cleaner, the lawnmower, the leaf blower, motorcycle, dirt bike, that kind of stuff. Anything that's highly repetitive, like a lot of wrist flexion and extension, potentially from work or real repetitive use, I would stay away from, especially in the early kind of first 2-week period after surgery. So it's kind of maybe a broad category, but limit the repetition, limit the vibration, limit the lifting to 2 or 3 pounds. Most other things should be safe. Let's see, question looks like patient specific about a fractured scaphoid affecting carpal tunnel syndrome. I guess that is hard to answer, whether or not it's a new fracture or an old fracture. We absolutely see patients that develop carpal tunnel after acute trauma, which in most cases is likely due to the localized swelling and inflammation. If it is an old injury, potentially if it has developed arthritis or abnormal mechanics to the wrist or the hand, then it could possibly indirectly affect carpal tunnel. I'd say usually it's not a one-to-one direct relationship, but absolutely possibility that there's some indirect relationship. Happy to answer any more questions if we have. We may be getting close to the end there, but I'm happy to answer more if anything comes up. Question is, why does compression begin? A very good question with, I think, a very long answer going back to the risk factors. For some people, I think it's just a combination of life and time. Certainly, the activities that we do, some of those medical comorbidities or medical conditions can contribute to it. But I think the end result is there is swelling or inflammation within the carpal tunnel that then leads to decompression. So where does that swelling and inflammation come from? So many of those things we mentioned. Likely there's also some dietary contributions. There's been good studies showing that there is some genetic component. Certainly there seems to be whether it's direct genetic component or related to other medical issues that could be genetic, that there are higher rates when we look at families compared to unrelated patients. So good question, long answer, but essentially whatever the underlying cause is, it leads to swelling and inflammation in the carpal tunnel around the nerve, and that leads to compression of the nerve. Okay, let's see. Oh, good question. If both hands need surgery, how long between surgeries? Great question. So we talk options. So when I have a patient come in with carpal tunnel that's symptomatic on both sides, I will often operate on both sides simultaneously. So we'll call it bilateral endoscopic carpal tunnel release. Most patients I think are pleased with doing both at the same time because you get to go through the recovery. While some things are certainly a little more challenging in the early period, you kind of get to recover through both as opposed to having to restart. It's always a discussion, kind of patient preference. Sometimes it depends on how much help you have at home, job duties, getting back to work, if it makes more sense for you to recover through both at the same time versus kind of have one normal hand while you recover from one and then switch over to the other. We've got good studies that most people can perform self-care pretty quickly after bilateral carpal tunnel surgery, probably within 3 to 5 days. So I think if patients have some help at home, they can do it. To answer your question directly, if you're going to separate it out, I tell patients you're in charge. I'll see you back after your first post-operative visit. Let's say we do your left side. If you're doing well, you're happy with your recovery, you're happy with your function, oftentimes we'll go ahead and set up your right side at that point and do it a week or two later. I would say most people separate them by about 6 weeks, but I've done them as soon as 2 weeks apart. And then in some cases, people's symptoms on one side are very mild and they come back 6 months later, a year later, and we do the other side. But can do both at the same time, which can be very functional. Can do them kind of as early as 2 weeks, but I'd say about 6 weeks is probably average, 4 to 6 weeks between the two if people are trying to get them done relatively soon. So question is, one hand is severe, the other is light. Do I need surgery in both? Kind of gets back to what I was just talking about. I think that's definitely a good question, good discussion to have with me or whatever surgeon you wind up seeing. And what I'll tell patients is let's focus on your symptoms. If one is very mild, very minimal, it's manageable with things like wrist splints and non-op. Sometimes we just choose to watch that one, understanding that it could get worse down the road and need treatment. A lot of patients will say, hey, well, my right hand's worse than my left hand, but my left hand still bothers me. Let's go ahead and treat both so that I don't have to come back and do it later. I think that's really just a a discussion with your surgeon, personal preference, managing all those kind of pros and cons of treating both versus treating one expectantly. So question, patient had a wrist fracture at age 15, now in their 70s, have had carpal tunnel symptoms for decades. Are you a good candidate for surgery? I think same thing, personal, good to have a visit with me or a surgeon to talk through it. In general, I would say yes. I think most people, if they have carpal tunnel syndrome, we can treat it. I think the big question would be is this patient in that small subset of patients where it is so chronic and so severe that you would not get much symptom relief, but we potentially keep it from getting worse. Although many times people that have had it for years or decades will still get some symptom relief. But I'll tell patients, hey, likely your recovery is going to be a little longer. The chance of all of your symptoms going away are certainly going to be lower than a patient that's had it for a shorter period of time. But I think it is always reasonable to, number one, evaluate, have us take a look at it, and potentially treat surgically if it's symptomatic. And many patients that have had it for a long time have surgery and still get symptom recovery and do quite well. So question about if the median nerve is damaged, what's the result? Great question. So that's our, kind of most devastating complication, which is incredibly rare. I think I've seen maybe numbers in 1 in 10,000. But if that nerve is cut, the way the nerve works as it runs through the palm, it would basically, if let's say worst complication possible, that nerve was cut in half, you would lose sensation to the palm side of the thumb, index, middle, and part of the ring finger. And so that would be complete sensation loss if the nerve was truly cut in half and complete. That nerve has a little small, what we call motor branch, doing some of the small muscles in the thumb. So it would lead to wasting away of these muscles and significant weakness with pinch and squeezing. The way the nerve works would still be able to flex and extend the fingers, make a fist, but would absolutely develop some weakness in the thumb, pain. Any sort of injured nerve will cause pain and complete sensation loss. So absolutely devastating injury, highly, highly uncommon. And even in most of the reports of nerve injury, they are partial nerve injuries, not complete cuts. But yes, if that happened, if the nerve was cut in half, it would be a devastating injury and lead to those issues. Okay, I think we might be getting towards the end. I'm happy to answer any more, but not seeing anything else pop up. Oh, we got another one. Let's see. Can compression alone cause nerve damage just as you described? I think if I understand the question, then yes. Long-term carpal tunnel. So untreated, severe carpal tunnel, let's take it to the, complete end result. If your nerve has so much pressure on it and for such a long period of time, then yes, it could ultimately lead to permanent loss of sensation in that distribution and absolutely weakness in the thumb. Those are the patients that I see that have wasting in those muscles, a lot of weakness with pinch, also some with grip, diminished sensation. And so the short answer is yes, if you've had long-term severe compression leading to nerve damage, you can get symptoms very similar to having the nerve being cut in half. And those patients, when we treat it surgically, that recovery is very, very slow. And I tell people, I hope we get better, but it's going to take a long time and the nerve will never recover back to normal if it's truly that severely compressed. So if I wake up with hand numbness, are there specific exercises to improve symptoms? So I think that for this patient, the number one thing is wearing a wrist splint if you're not already. The idea of keeping that wrist in a kind of flat or neutral position at night. A lot of patients, a lot of people, we naturally sleep a little curled up, which causes increased pressure on the nerve. And so if you're not already, come to our clinic, go over the counter, get a wrist brace or splint that keeps your wrist in a kind of neutral straight position, sleep in that at night. For some people, that is a absolute game changer. You get immediate relief of that numbness and tingling. There are certainly some patients where it doesn't help, and occasionally patients just don't tolerate it. The number one thing would be a wrist splint at night. We do think sometimes some wrist extension or kind of wrist back exercises help open up that space for the nerve and can give you some temporary relief, maybe not long-term, but if you're developing that numbness in the morning, really kind of stretching out the elbow, sorry, a little hard for me to show, pulling that wrist back can help wake up the nerve or potentially decrease those symptoms a little quicker in the morning. Right. Any other questions coming? Appreciate that. Someone says thanks. So yeah, happy to be here, happy to help. I hope that was some good information, both non-surgical and surgical treatments, and I'm happy to evaluate anybody in clinic and talk through options directly. And again, big picture, this is patient specific, depending on, you know, your goals, your symptoms, how long they have been and how bad they are, and that really kind of directs our treatment. So happy to be here, and hopefully that was helpful for everyone. So thank you very much.